Blog Talk Radio. Welcome to today's episode of mPatient Myeloma Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom. Now, because this is the last show of 2014 as we head into ASH and the holidays, we wanted to let you know that we will be continuing this show throughout 2015 with a new name, Myeloma Crowd Radio. So I will keep you updated online on the mpatient.org and Myeloma Crowd websites about the change, so you can watch for upcoming announcements and postings about that. If you'd like to receive a weekly email about past and upcoming interviews, you can subscribe to our newsletter on the homepage of either site or follow us there on Facebook or Twitter. Now, Dana Holmes' Mambo for Myeloma Awareness campaign continues to gain support, so feel free to watch the videos, make your own Mambo video, and share myeloma awareness with your friends and family. One last announcement. Today is the final day to donate a song for our Songs for Life contest for myeloma research. So if you know any musicians, you can help spread the word. We've had over 70 songs donated, which is fantastic. If you want to help choose which songs end up on the final album, you can go to songsforlife.org on the 2015 submission page, listen to the entries, and like your favorites. This is one of our initiatives to use music to help myeloma and cancer patients as they go through treatment while funding myeloma research at the same time. Now, today we are pleased and honored to have with us, as our last show of 2014, Dr. Vincent Rajkumar of the Mayo Clinic to explain new myeloma guidelines that make major changes to how myeloma is diagnosed and potentially treated. So, Dr. Rajkumar, welcome.
Thank you so much, Jenny, for having me on the show.
Let me just give a short introduction for you, if you don't mind. Dr.
Sure.
Rajkumar is a professor of medicine and chair of the Myeloma, Amyloidosis, and Dysproteinemia group at the Mayo Clinic in Rochester, Minnesota. He chairs the Eastern Cooperative Oncology Group, or ECOG, Myeloma Committee. He's published more than 500 articles and 350 abstracts, and his career was profiled in a November 2011 issue of The Lancet. He has an extensive research program in the field of plasma cell disorders and has led numerous phase 1, 2, and 3 clinical trials investigating the role of new agents in myeloma, including the very important randomized trial that led to the approval of thalidomide in the U.S. He also leads several large studies investigating the nature, prevalence, and progression of various monoclonal gammopathies, including myeloma. His lab research has been focused on investigating new agents in myeloma and studying the role of angiogenesis in various plasma cell disorders. He's been continuously funded as an independent investigator by the NCI through R01 grants, serves as an associate editor for the Mayo Clinic Proceedings, section editor for multiple myeloma and related disorders for the journal Leukemia, and is an associate editor for the European Journal of Hematology. He's deputy editor of the Blood Cancer Journal and received the Relentless for a Cure Award from the Leukemia and Lymphoma Society in 2010 and an award from the American Society of Clinical Oncology, or ASCO, in 2011. So, Dr. Rajkumar, we are thrilled that you're here with us today.
Thank you so much for that nice introduction. I'm really pleased to be here.
Well, there have been a lot of changes made by the International Myeloma Working Group in general. So maybe, and this is highly relevant for how myeloma is treated and how it is, diagnosed and then treated. So if you could give us an idea of the International Myeloma Working Group in general, first, as just a preview, who's involved, how it came about, and then we can move forward to talking about the different guidelines.
Sure. The International Myeloma Working Group is a group of right now about 180 researchers who are involved in the diagnosis, treatment of plasma cell disorders, including multiple myeloma. The International Myeloma Working Group is also known as the IMWG, is the research arm of the International Myeloma Foundation, the IMF. It was set up initially to make sure that collaborative research happens across countries and across institutions to answer important questions in myeloma, as well as to provide diagnosis and treatment guidelines that are applicable to the whole world. And some of the major publications of the IMWG were the 2003 diagnostic criteria for multiple myeloma and related disorders, which has been used all the way till now, and the International Staging System, which is how multiple myeloma is currently staged, and the International Myeloma Working Group response criteria, which are used as a response in all myeloma clinical trials. There have been numerous other guidelines that the IMWG has issued, including how to treat patients with newly diagnosed multiple myeloma, the role of imaging modalities, vertebroplasty, and so on. The most recent publication is the one that we are going to discuss today, which is the International Myeloma Working Group updated criteria for the diagnosis of multiple myeloma.
And the whole point, it seems to be, is to establish consistent practice worldwide for multiple myeloma. Is that one of the major goals?
The IMWG's major goals are to make sure patients receive the best possible care so that we provide the most accurate diagnostic, prognostic, and treatment guidelines for that can be universally used. The IMWG is not only a body that issues guidelines, but also conducts several original research projects, and that is a second major goal, and that's played a very big role in many areas so far.
Okay. Well, from reading that paper that I was able to see, the content is rich and there are many, many changes. So I will let you decide how you would like to launch into the changes, and then we can talk about relevance and what it means for myeloma patients.
Sure. I think the first question to ask ourselves any time we want to change something is like, why are we going to change something? And in this case, change was really needed based on numerous advances that have happened in the last decade or so in the treatment of multiple myeloma and related disorders. Number one, we needed to change the diagnostic criteria for myeloma because current criteria required that patients be diagnosed only after end organ damage had already happened. Now, that was fine when we did not have much in the way of treatment for the disease. It is not fine when we have several exciting options which have more than doubled the survival of multiple myeloma. So waiting for end organ damage to happen is not going to serve our patients well, because it means you are telling the patient, I will treat you after you get renal failure or after you get lytic bone lesions or pathologic fracture, but not before.
Mm-hmm.
Number two, we became aware that we don't need to wait because we can actually, using new laboratory testing and and imaging modalities, modern imaging modalities, diagnose end organ damage fairly early. So we don't need to wait for skeletal survey to show changes or creatinine to change. And finally, we have accurate biomarkers that tell us, if you look at patients with high-risk smoldering multiple myeloma, who are the patients who already have myeloma but have just not declared themselves and are almost guaranteed to declare themselves within 2 years, so that waiting is only going to cause harm and not provide any long-term benefit. So the fact that we had accurate biomarkers now made it easier and important to change the criteria. Now, what did we change? We changed the diagnostic criteria for multiple myeloma to include 3 new biomarkers that allow us to make the diagnosis of myeloma and initiate therapy before end organ damage occurs. The end organ damage we've typically waited for is called CRAB, hypercalcemia, renal failure, anemia, or bone lesions that are felt to be related to the plasma cell process. In addition to the CRAB, now we have said that patients who have more than 60% or more involvement in the bone marrow, or a free light chain ratio of 100 or more than one focal lesions on MRI, are considered as having multiple myeloma, even without symptoms and even without the presence of CRAB features. So that will allow the diagnosis of multiple myeloma to be made early. In deciding on these 3 factors, we wanted to make sure, number one, we had that these markers were accurate, and we have data from studies to support that. We did not want to use risk factors that would result in a large number of false positive diagnoses, errors in diagnosis.
Right.
The second thing, we wanted to make sure it was data-driven and there were at least 2 or more independent studies that validated these biomarkers. So each one of these 3 has more than 2 studies that show that patients with such features will progress with almost 80% certainty within the next 2 years, and more than 90% within the next 3 years.
So you have a lot of validation.
So that would be the most important change that we made.
Mm-hmm. And what testing has improved to be able to make these changes?
Well, the serum free light chain ratio is very useful because when it's very high, like 100 or more, it indicates patients who are at high risk for renal failure. And renal failure is one that we want to avoid because once patients get it, even if you manage to reverse it, the survival does not seem to improve back to baseline. Imaging has changed. We have computer tomography, CT scans, PET-CT, which is positron emission tomography, which can identify lesions well before the skeletal survey can, and magnetic resonance imaging, which is the MRI. These imaging modalities can be used to diagnose myeloma early, and in the case of MRI, before even lytic bone lesions happen. And so those enable us to make the diagnosis early. It means that a patient with smoldering myeloma diagnosed today will be called as myeloma if they meet one of the 3 criteria. But it also means that a patient with smoldering myeloma who's being followed does not need to wait for the full-blown CRAB to happen. But if they're watched carefully, particularly high-risk patients, the diagnosis can be made early based on free light chains, bone marrow changes, or MRI changes.
Okay, well that's going to be critical. I know you'll talk a little bit more about that. So you mentioned that I sort of interrupted you. You were talking about the diagnostics and how you have the 3 new markers, and that's a big change.
Yes.
What else would you like to cover about the changes?
Absolutely. The paper is like
so long.
You probably read, very dense. It's got
yes.
a lot of data, a lot of information, and a lot of changes. Some of these other changes are also important and worthwhile going through. So, for example, solitary plasmacytoma. This is a condition that is in between smoldering myeloma and multiple myeloma. In this condition, patients have 1 lesion, so it's not multiple lesions, but it can be cured. And so we need to make the diagnosis correctly. And so the new criteria classify solitary plasmacytoma into 2 categories: patients who have patients who have normal bone marrow, because these patients have almost a 90% chance of being cured with radiation alone, and patients with solitary plasmacytoma who have less than 10% involvement of the bone marrow with clonal plasma cells, where the risk of recurrence is high, and therefore these patients are candidates for trials investigating adjuvant systemic therapy. And that's a change. And we have also made an important change that when you make a diagnosis of solitary plasmacytoma or smoldering myeloma, that we recommend now that the patients have at least, at minimum, a CT scan of the whole body, or PET-CT of the whole body, or an MRI of at least the spine and pelvis, if not the whole body. Now, this will therefore make sure that the patients we classify as solitary plasmacytoma and smoldering myeloma are correctly classified and not understaged. Additional changes that we have made are in regards to follow-up of monoclonal gammopathy of undetermined significance. MGUS, or MGUS, is the pre-malignant stage of plasma cell disorders. And it can be divided into low-risk, intermediate-risk, high-risk groups. And the low-risk patients with MGUS are the ones who have only a 2 to 5% lifetime chance of getting myeloma and do not need to be worried so much about myeloma because they have more than a 90-95% chance that nothing will happen in that regard. And so we have recommended that if a patient appears to have low-risk MGUS, that a bone marrow biopsy can be deferred, and that's a judgment call, as well as that if the first 6 months follow-up results are stable, that further follow-up can be deferred as well until symptoms happen. And this will then enable patients with this low-risk MGUS to have a better quality of life, because their risk of getting myeloma is very, very low.
And let me ask a follow-up question. How do you classify MGUS patients? I haven't heard of that before.
Well, if you take just a diagnosis of MGUS, which is less than 3 grams of monoclonal protein, less than 10% plasma cells in the marrow, and no evidence of end organ damage or any of the new myeloma-defining events I mentioned, the general rule is that patients will progress at a rate of 1% per year. And 1% per year means in 10 years, patients with MGUS have a 10% chance of getting myeloma-related disorder. It also conversely means that there's a 90% chance they won't get myeloma-related disorder. Mm-hmm. Now, using the size of the M protein, whether or not the M protein is less than 1.5 grams per deciliter or more than 1.5 grams per deciliter, using the type of M protein, whether it's IgG or something else, and the serum free light chain ratio, whether it's normal or abnormal, you can classify MGUS patients into low risk. These are patients who have none of the risk factors, patients who have one of the risk factors, 2 or all 3. So a patient with a M spike of less than 1.5, IgG, and a normal free light chain ratio has only a 2% lifetime probability of getting myeloma-related disorder. And that's much less than 1% per year. And it's good for them to know that, 98% of the time they're going to go through life without getting one of this. And that means they can also focus on other things that are important, cholesterol, cardiac disease, and not just see the hematologist.
Mm-hmm. I think that would be critical.
So this was published in Blood in 2005 and has been validated by others as well.
Well, as part of this, we might want to include some of that in our transcript, just
Absolutely.
for patients who are now diagnosed and want to know how they are classified.
Absolutely. And, Blood Journal allows us to reproduce content by the author at no cost. So I will be happy to provide you links for the actual tables which show you how to classify MGUS.
Okay, that'd be great. And is there anything else about MGUS you'd like to share, or?
Well, there is a new type of MGUS that was described by Dr. Dispenzieri called light chain MGUS that was published in the Lancet Oncology. In the Lancet a few years ago. This is a condition that the new IMWG criteria has refined the diagnostic criteria for. The risk of progression in this group of patients is not well known. The diagnosis itself is made using the serum free light chain assay. So that's one thing for people to know.
Okay, terrific. Do you want to continue? I mean, your list is very long, so I want you
sure.
I want you to make sure you explain everything as much as you want to explain it. But
sure. So let's just go through step by step. What else has changed with myeloma diagnostic criteria? Patients with multiple myeloma are at risk for renal failure. Patients with any monoclonal protein disorders, like including MGUS or smoldering myeloma, are also at risk for getting renal problems. We clarified that only light chain Cas nephropathy will count as a myeloma-defining event. That there are other renal problems that patients can get as a result of monoclonal proteins, but those are not considered as multiple myeloma or as a malignancy. And this includes light chain deposition disease, light chain amyloidosis, membranoproliferative glomerulonephritis. So that's been clarified so that it's very clear what kind of renal damage qualifies as myeloma and what doesn't. We've also clarified that not everybody with multiple myeloma will have a monoclonal protein, and that patients without a monoclonal protein but clear-cut evidence of a clonal plasma cell disorder and the myeloma-defining events are also considered as having myeloma. And so we have clarified that you do not need to have a monoclonal protein to make the diagnosis of myeloma. We've clarified that the type of bone changes that count as myeloma are osteolytic bone destruction seen on skeletal survey, CT scan, or PET-CT scan. Merely having compression fractures, which could be related to osteoporosis, or changes on bone densitometry is not enough. Mm-hmm. These set of changes that I just discussed enable us to make sure that we are not over-diagnosing multiple myeloma. With the greater use of more modern imaging technologies, we run the risk of labeling patients with MGUS as myeloma, and these patients will not be best served by being started on chemotherapy. So these changes are very important to make sure that we are making the diagnosis accurately and that we are neither underdiagnosing nor overdiagnosing multiple myeloma.
Well, that it seems like a tricky balance to be able to treat it early.
Absolutely.
So it doesn't progress, but not to treat it when it's not necessary. That's difficult.
Absolutely. Because the more sensitive you get with your testing, the risk you run is that you will overdiagnose. Mm-hmm. And you will have a lot of false positives, patients who really do not have multiple myeloma and would do well for years, who will then run the risk of getting chemotherapy and stem cell transplant. And we just want to avoid that. So I think the one good thing about this International Myeloma Working Group coming together for this is you have the collective wisdom of like 180 people. And particularly with this paper, I received comments from more than 80 of the world's best experts on developing this document, and 34 authors from around the world. And so we managed to look at almost every paper that was done which pertains to this diagnostic criteria and to any changes we are planning to make, so that any change has had a lot of thought gone into it. And it's not just me, it's Dr. San Miguel and every one of the 34 authors and the 50-odd people who provided comments that we were not able to name as authors.
Well, it's amazing collaboration.
Absolutely. It was one of the best, and it took a long time because, we had to first generate data for any of the changes that we were going to make, and that generating the data, publishing the data, and then working on the change of the diagnostic criteria took a whole 3 to 4 years amount of effort into this. Then moving on to smoldering multiple myeloma, we again the criteria are necessarily updated because when you change the diagnosis of myeloma, then the diagnostic criteria for smoldering myeloma automatically change. So the updated definition is provided, and there will be a paper that is authored by myself and Dr. Landgren and Mateos on smoldering multiple myeloma, which takes into account the revised definition that will come out shortly. Then moving on, as I mentioned, we have made changes to the follow-up recommendations for MGUS. We also made slight tweaks to the classification of MGUS, recognizing that not all types of MGUS progress to multiple myeloma. Most patients with IgM MGUS actually run the risk of progression to Waldenstrom's macroglobulinemia and amyloidosis. And so we have classified MGUS into non-IgM, IgM, and light chain types, each one with a slightly different risk of progression and a slightly different mode of progression. Fourth, we revised the classification of solitary plasmacytoma, which we discussed earlier. We made changes to the follow-up recommendations, also discussed earlier. And I think the most important thing is we have set a threshold, a line in the sand, so that the diagnostic criteria are living and evolve with time. So we made a final recommendation that future biomarkers, which meet the threshold that we have now set, which is able to identify patients with smoldering myeloma who have an 80% risk of progression within the next 2 years in 2 or more independent studies, those criteria, those biomarkers can then be incorporated into the myeloma diagnostic criteria in the future. So I think as time goes on, we will have new biomarkers added. Some of the most promising ones include immunophenotyping of plasma cells, rise or change in monoclonal protein levels over time, circulating plasma cells, as well as changes in bone marrow plasma cell proliferation. I think all of these are going to come in the future, and that's another major recommendation in this paper, that the criteria evolve.
And it seems like it would need to, because you're learning new techniques. How did genetic features weigh in on that at all?
I think cytogenetic features will also play a role in the future, and it will evolve. Right now, if you take patients with smoldering multiple myeloma, we generally say patients have a 10% per year risk of progression. But that is true if you take all patients. We do know that patients with 414 translocation, 17p deletion, or 1q amplification have a higher risk of progression, more in the order of 25% per year. Patients with hyperdeployed myeloma have an intermediate risk of progression, and all other abnormalities have a lower risk of progression. So this will play a role in the future as we update the criteria. None of them rise to the level by themselves of the 40-45% risk of progression in a year that we need to make to reclassify as myeloma. But I think combining a cytogenetic change such as 414 translocation and 17p deletion with another biomarker, you may meet that threshold. And so that's something we'll be working on.
And can you explain immunophenotyping of cells, what that is? I'm not familiar with what that means.
Yes, you often hear about the word flow cytometry, multicolor flow cytometry, and multiparametric flow cytometry. Basically, what flow cytometry does is look for markers on the plasma cells with immunofluorescent tagged antibodies. And multicolor flow cytometry means you're able to add like 7 or 8 antibodies into a single tube to see what kind of antibodies, what kind of antigens does the plasma cell have. And we are now looking for certain markers on the plasma cell. For example, CD56 is a marker of malignancy. It is seen in plasma cells in myeloma patients, but not in plasma cells of normal patients. And so we can use the presence of CD56 to say, okay, this cell is probably malignant. Same way, CD19 is usually not present in myeloma cells, but is present in more normal plasma cells, and we can use that as a marker. So if you have a tube with 56 and 19, knowing whether the cells are 56 positive and 19 negative will tell you whether the plasma cells you're dealing with are malignant or not. And just expand this to 8 markers, then you have multiparametric flow. So you look at all 8 markers together and make a judgment call based on data, and hopefully soon based on computerized analysis on whether what we are looking at is a marker of malignancy or not. And certain combinations of these antigens will tell you whether patients are at high risk for progression or not. So what the Spanish group has done is look at smoldering multiple myeloma patients with a multicolor flow. And what they find is if the plasma cells that you see in a patient with smoldering myeloma, if more than 95% of those cells are aberrant, that means they have a phenotype that is more consistent with myeloma rather than normal plasma cells, that puts them at a high risk for progression, 25% per year, 50% over 2 years. That was the basis of the trial they did in high-risk smoldering myeloma. They included such patients and then found out that they do progress rapidly, and that if you give lenalidomide dexamethasone therapy, that the rate of progression was slowed. So that's what we mean by immunophenotype. We are basically fingerprinting the plasma cell.
Well, thank you for that very good explanation.
Whether it's malignant or not.
I wasn't making the connection between the word immunophenotyping and the flow cytometry. But a follow-up question, when do you think a computerized flow cytometry will be available?
Very soon. Again, the Spanish take the credit. Dr. Orfeo, Dr. Paiva, Dr. San Miguel. They've been working hard on a automated method, which is all part of the Black Swan Research Initiative of the IMF. The major problem with flow cytometry is that it varies lab to lab, what markers people use, how they interpret it, and more importantly, it requires an expert, and experts vary. Experts have to make a judgment call, and judgment can vary. So then what Mayo reads out may not be the same as what MD Anderson reads out or the Spanish read out. And we wanted to eliminate such variation. And secondly, no expert can know. I mean, it's hard enough for me to know what to make out of 2 or 3 markers, let alone 8 markers, all expressed to various levels. In terms of what does that mean? A computer, on the other hand, can look at 5 million events, count every plasma cell, and match each plasma cell to a normal profile that it already knows exists from a database. And will tell you whether, if you see 20 plasma cells in this patient, are these normal cells or are they malignant? And it's able to do it much better than an expert, because an expert's limited by only what they know, and unfortunately the variation is so much that it's not possible for the human brain to look at 8 markers simultaneously at various levels of expression. I think it'll be available soon, hopefully within 1 year. It'll be a research test, and I hope that within a couple of years it'll become available in the U.S. as a clinical test.
Okay, well, that's perfect. We talked to Dr. San Miguel a little bit on this show about that, but he didn't give a time frame. And myeloma experts are few and far between, especially when it comes to a community practice. So standardizing that.
Yes, I mean, the goal with this,
fantastic.
Absolutely. The goal with this is to make it something that most labs can do, most reference labs can do, and most send-out tests that people send and that the readout will be the same wherever you send the test, because the method will be standardized. That's the goal.
That's a great goal. Great goal, and we're very appreciative of the IMS Black Swan Research Project for that. So thank you for we're very appreciative for everyone's involvement in that.
Thank you.
Okay, so I don't want to interrupt your rolling list.
I think we've gone through the list. I think if you want a summary, it's like there are changes in how myeloma is diagnosed, and now we can diagnose myeloma before CRAB using accurate biomarkers. We have updated definitions for smoldering multiple myeloma and solitary plasmacytoma. We have updated the follow-up recommendations for MGUS and smoldering myeloma, particularly high-risk smoldering myeloma, so that patients do not need to endlessly wait for the CRAB features but can be diagnosed early. And we have laid down the metric by which new biomarkers will be evaluated and incorporated into the criteria.
That's a great summary. Now, maybe you can talk for a moment about the significance and how this gets put into practice in a very practical way inside the clinic.
Well, we have been already, many of us have been doing this, in the sense that when I have been seeing patients with more than 60% plasma cells or free light chain ratio more than 100, and they do not have CRAB, we have been saying that based on all our research, this is really multiple myeloma. It is not smoldering myeloma, and treating them as such. Many of us have been doing it. This just formalizes that and makes sure that the community recognizes that you do not need to wait for CRAB. Similarly, many of us have already been using MRI, PET CTs, and CT scans to diagnose multiple myeloma without waiting for skeletal survey changes to happen. This again formalizes that. Hopefully it eliminates any insurance problems for patients who undergo these procedures, because it's necessary now for diagnosis. It's established by the world experts that this is not just a suggestion but a requirement for the diagnosis of smoldering myeloma or solitary plasmacytoma. So practically, I think the main thing would be that patients will be diagnosed early, and we want patients to be diagnosed early and treated. we will know in trials which patients come in through this route, and we can see how the impact of these criteria are on those patients in future trials. But I expect not just the practice to change, but also new clinical trials will use the new criteria for trial entry.
Well, let's talk about clinical trials. How does this create different clinical trials or newer approaches to clinical trials?
Well, I think the myeloma portion would be easier because we have previously we would say that the first line in every myeloma trial would be patients should have multiple myeloma based on standard criteria, and they will refer to the old 2003 criteria. Mm-hmm. Now they will refer to the 2014 Lancet Oncology paper, mm-hmm. and that then would move forward. But the problem still remains for smoldering multiple myeloma patients. I think we want to make clear that these new criteria do not change the fact that smoldering myeloma patients exist and high-risk smoldering myeloma patients exist. And the high-risk smoldering myeloma patients are still the same as the study that was done by the Spanish looking at Lendex. And we still need clinical trials for that group. Just because we have upstaged the ultra-high-risk group doesn't mean the high-risk smoldering myeloma goes away. These patients still pose a dilemma as to whether they should be just watched, whether they should be treated on clinical trials, or whether they should just be treated with therapy, such as Lendex. And so that's a debate we still need to have. That's a group that we still need to conduct clinical trials for. Matter of fact, we have in the U.S. the Eastern Cooperative Oncology Group trial that Dr. Sagar Lonial is leading, looking at lenalidomide for high-risk smoldering multiple myeloma. And so such trials will continue. And I want to emphasize that the change in the criteria doesn't mean the high-risk smoldering myeloma went away. It stays, and it's pretty much untouched. It's still the same as it was before the criteria.
So while there may be more opportunity for patients with, I guess, earlier stage features to now get into traditional multiple myeloma clinical trials, you're saying that the whole field with MGUS and smoldering myeloma really needs to be almost segmented and offerings provided to these patients that are unique
Absolutely.
to their situation. So let's talk
Absolutely.
about that a little bit, because the Mayo Clinic has historically had really deep talent and work done in the MGUS smoldering myeloma area. And in one past interview, we talked with a researcher at Dana-Farber talking about how they wanted to really target this population as well. So do you want to share how you do that across an international community of smoldering myeloma patients?
Sure. First of all, we have been collaborating with many centers on the prognosis of patients with monoclonal gammopathy of undetermined significance and smoldering myeloma, and identifying biomarkers and identifying therapeutic strategies. We have had a long-standing collaboration with the Dana-Farber Cancer Institute with Dr. Ken Anderson. We were part of the myeloma spore that Dana-Farber and Mayo had jointly for many years, and now Dana-Farber continues to have. This spore had a project dedicated to early diagnosis and treatment, which I was fortunate to be a project leader for. So we've had long-standing experience. Many of the studies that I did and published were supported by the Dana-Farber spore led by Dr. Ken Anderson. So I'm very appreciative of that. Secondly, we have also been working with the various institutions that are part of the IMWG in either collaboration by ideas or actual sharing of samples to do studies or sharing of data. For example, many of the biomarker studies that were used to validate the IMWG new myeloma diagnostic criteria were done in one institution, and then each one of the three were replicated by the Greek myeloma study group. Without that validation, we couldn't have changed the criteria. So we worked together, and now Dr. Hillengas is leading an effort bringing in imaging from many different centers, the actual images, the imaging reports, to see, how we can better diagnose smoldering multiple myeloma, how we can better use the imaging information in prognosis and treatment decisions. And finally, there's always collaborative groups looking at treatment. So the Eastern Cooperative Oncology Group, for example, and the NTC and the National NCT and the National Clinical Trials Network offers opportunities to work together. In the U.S., multiple institutions can come together to do trials that it's not possible for one institution to do. And the example for that would be the ECOG smoldering myeloma trial, the SWOG trial that's going to come up for solitary plasmacytoma with minimal marrow involvement. And the Alliance is planning a smoldering myeloma trial as well with novel therapeutics. So many of us work together in that area because it's just not possible to do it in one center.
Well, I think it looks like it's following the model that children's cancers have followed, and they've been really effective in that, and running these cooperative trials and collaborating at a very deep level. And it seems to me that myeloma is a very collaborative community. So.
Oh, absolutely. I don't want to compare across disease groups, but
right.
If you just look at the myeloma field, most of us work really well with each other, collaborate with each other, are friends, and it's just really, really nice. There's a real desire to work together, and it's just very, very good. Here in the U.S., myself, Dr. Orlowski, and Richardson lead the three cooperative groups, the ECOG cooperative group, the SWOG, and Alliance, and we plan our trials together so that, if we do a trial in ECOG, it's supported by everyone of the other groups, and vice versa.
Mm-hmm.
And we try not to overlap trials.
Well, perfect. Well, one of maybe two final questions for you, because this is a lot of information to take in. How do you share these new diagnostic criteria with not only the network of the 180 people who are in this group, but people who are treating myeloma throughout the world, so that they're consistently treating? Yeah.
Absolutely. This is going to be a challenge, and we have to, because many physicians who treat myeloma are seeing only one or two patients with myeloma a year. Mm-hmm. And they have very pressing issues in breast cancer and lung cancer and other more common malignancies to deal with, that it's very difficult to keep up with the literature. So we have to make aggressive education pitch to make sure that everybody hears it. So, yeah, we are working with ASH, hematology education sessions. I'm sure Dr. San Miguel will highlight this in his role as editor of Blood, associate editor of Blood. We will also work with the foundations and the pharmaceutical companies to make sure that the messaging gets across, that changes happen. And you are well aware that some of it has been made easier with social media. People like you mm-hmm. have been so helpful in spreading the word. What would have previously reached the 100 people who managed to read the Lancet Oncology article is now reaching thousands and thousands of people mm-hmm. because of social media and social media efforts by not just physicians but patients and patient advocates. It's just incredible.
Yeah, well, we'll continue to spread the word, and we can do several things to get the word out. So when you think about the smoldering myeloma patient group, we've talked for over a year and a half now in this series about the importance of participating in clinical trials. And sometimes those smoldering patients are in this kind of watch and wait. They feel like they're stuck. How important is it that smoldering myeloma patients also participate in clinical trials, as well as a higher percentage, hopefully, of myeloma patients?
It's very important, and I think the risk stratification will help, because not all smoldering myeloma patients need to participate in clinical trials testing early intervention, because for some of them the risk is low. So we can use several prognostic markers to look at smoldering myeloma patients and classify them into low risk and high risk. It's the high risk patients that really need to be studied in clinical trials. If they are not on trials, then they need to be followed up closely every 3 months or so. And they need to be, depending on the exact features, they may need, imaging like MRI or PET CTs to be done periodically to determine if they are progressing, so that we can take advantage of the new criteria and make the diagnosis early before skeletal survey changes or creatinine increases. Low-risk smoldering myeloma patients, on the other hand, can have some kind of reassurance that they are not going to get myeloma, and particularly as time goes on, smoldering myeloma is a mix of patients who have MGUS and myeloma mixed in with each other, and it's not like a disease in itself. So as time goes on, myeloma patients will declare themselves. And so if a patient with smoldering myeloma has had smoldering myeloma for more than 5 years, their risk actually goes down. It's not 10% per year, but it's more like 3% per year. And if they've had smoldering for 10 years, then the risk goes down to MGUS level of only 1.5% a year. That very knowledge can give quality of life improvement. I mean, if they're constantly going to think they're going to get myeloma 10% chance a year, that's going to affect quality of life. But if they know I have gone through with smoldering myeloma for 10 years and now my risk is actually much lower, that changes everything.
Yeah, that's the first time I've heard that. That's very exciting.
I think we need to educate people.
Yeah, very much so. I mean, you don't want to be living with that hanging over your head if you don't have to. That's terrific. Yes. Well, fantastic. Well, I don't want to take up all your time. I want to allow some caller questions. So let's open it up for caller questions. If you have a question for Dr. Rajkumar, please call 347-637-2631 and press 1 on your keypad. And we will start with our first caller at 936757. Go ahead.
Hi, Jenny. Hi, Dr. Rajkumar. This is Dana Holmes. It's really such a pleasure to speak to you. How are you? Wonderful.
I'm doing well. Thank you.
Thank you for taking your time out this morning. It's really been just so educational and informative. I know you know that we have a smoldering multiple myeloma group on Facebook, and we have about 200 members, and we try to share all of the information as best as we can. So your interview has been extremely helpful, and as have the guidelines. So thank you very much. I have a question, and it's going to be pointed to your last comment about the risk of progression, the 10% per year. Could you just elaborate a little bit more on that to really to help us understand, is that a cumulative risk? In other words, if it's 10% per year, at the 5-year mark, it's 50%. And then what happens after that? It becomes 3%. So does it become 53%? Is it cumulative in that sense? Is that the way that we should look at that? Or do we discount the first 50% altogether and start from scratch at year 5?
So, that's a great question. And if you're a patient, the way to look at it is this. You're diagnosed with smoldering myeloma today, and you want to know what are my probabilities that I will get smoldering myeloma in the next 5 years. If you didn't know anything else and all you knew was that you had smoldering multiple myeloma, the risk is 50% at 5 years, at an average of about 10% per year. And that also means that there's a 50% chance you will not get myeloma in 5 years. The way to interpret the next 5 years is, once you reach that point, let's say you've declared yourself, 5 years have gone by and no progression has happened. Now you want to know what the next 5 years are going to be like. That's not going to be 10% per year. It's going to be 15% over the next 5 years. It's 3% per year. Mm-hmm. And if you've gone through 10 years, then it's a conditional probability. Provided you've had smoldering myeloma since 2004, and now we are sitting in 2014, and you're still smoldering, now I can tell you that, your risk of progression is, from now on, is probably more likely to be only 1 or 1.5% per year, mm-hmm. or 5% chance in the next 5 years, which will dramatically change your outlook on life.
Oh, absolutely. Without a doubt. Even that hitting that 5-year mark changes the attitude immensely. Dr. Rajkumar, do you see gene expression profiling playing a role as a future biomarker?
Yes, absolutely. I think what gene expression profiling has the capability of doing is that it's we have many markers, and many of them can collectively affect one gene. And so it's possible to come up with a signature that's highly accurate and tells patients, what the odds are of, just the same way as it's useful in multiple myeloma. The question, though, is not so much what gene expression profiling will do, but what will it do in addition to the other ones that we already know, which are easier to obtain. So my question always is, if I already knew the fish cytogenetic classification, and I already know about whether there are circulating plasma cells or not, and the free light chain ratio, what's the incremental benefit of the gene expression profiling? Is it big enough to warrant the, however many $1,000s that it costs to get it?
And to replace the others that are not as...
if it can replace the others, and by doing the gene expression, you don't have to do any of these other ones, then it's a different deal. But if the others are going to be done anyway, then you have to really ask yourself what is the incremental value, and that's where we need more data to know what. But I think the SWOG group has published some data already. What we are looking for is incremental value, and again, there are two things here. One is a signature that is predicting for such a high risk progression that it's actually identifying patients with myeloma who should be called as myeloma and treated. And the second is a signature which doesn't quite go that far, but it identifies patients who are at high risk of progression so that they can be entered on trials.
Okay, because we earlier in the week, Dr. Morgan was interviewed, and he stated that he is likely going to be offering the high risk to progression smoldering group based upon his 4 gene expression risk score, that being 1.5 to 2 years at a risk to progress to active myeloma. So it sounds like the ultra high risk, which is now redefined as newly diagnosed myeloma, but he is thinking of offering CD38 monoclonal antibody therapy as it targets the myeloma cells directly to his cohort of patients. What are your thoughts about a trial such as that?
Oh, it's exciting. So as I mentioned earlier on, what we have renamed as myeloma is really a tip of the iceberg. That's just the highest of the high-risk smoldering myelomas. Removing them or including them doesn't change the fact that smoldering myeloma still consists of 2 groups, patients with high-risk smoldering myeloma and patients with low risk. The patients with high-risk smoldering myeloma will be defined as those with a median time to progression of about 2 years. And those patients need clinical trials. There's one trial that's going on in the U.S. that is with lenalidomide. We need more. We need more trials, and so Alliance is planning one. People need to look at antibodies. People need to look at anything that we can do to delay progression of this cohort of high-risk smoldering myeloma patients.
Wonderful, great.
So if a gene expression signature can identify those people accurately, then it should be used.
Okay, and it's really just a matter of, as you said, having independent studies supporting the gene expression profiling as maybe one of the best biomarkers out there.
Yeah, it needs to meet those two. It needs to meet those 2 thresholds. One is a 80% risk within 2 years, which usually looks like as a median time to progression of 1 year. And secondly, independent validation in 2 or more studies.
And what about plasma cell labeling index? Does that have any role in as a future biomarker? Because I know it's been used, but it doesn't seem to be used much at all.
Well, the plasma cell labeling index was a slide-based assay that was done in very few institutions, and now it's no longer done, even at Mayo Clinic. We are doing plasma cell proliferation estimation using S-phase on flow cytometry. What needs to be done, and we are working on it, is to identify the thresholds. And so it won't be called plasma cell labeling index, but it will be called S-phase or plasma cell proliferation index, and it will come back into the mix, surely.
Great. Dr. Rajkumar, thank you. Thank you for your time. Thank you for everything that you're doing. This paper that you are referencing, do you have an ETA? Is it another few weeks, another month or so? When can we expect to see it?
The smoldering multiple myeloma paper?
Yes.
That I mentioned? Yes, that paper, which takes into account the changes to the myeloma diagnostic criteria, will be published soon. I just don't know when.
Okay.
But it
well,
is already
you can count on
press.
me to keep asking you when. Very anxious to see that. Okay. Well, thank you again for your time. Thanks, Jenny, for taking the call. Have a great day.
Okay, thank you so much for your questions. It's wonderful. Okay, our next caller is at 204-6956. Go ahead with your question.
Hi, thank you. I have two questions. Hopefully we have time. First of all, thank you for the radio show this morning. It's fascinating, and I really appreciate it.
Thank you.
My first question is, since it looks like we'll be able to start diagnosing myeloma patients much earlier, is the protocol for putting most transplant-eligible patients directly into having a transplant, or is there maybe some wisdom in seeing if those patients are receptive to initial therapy, and if they are, letting that play itself out before going into transplant?
It's a great question, and I don't think the change to the diagnostic criteria really impact that question, but that question's been there for a while. And it's getting more and more important as we find out that we can achieve really deep responses with drugs alone. The strategy for this varies across institutions and between the U.S. and Europe even. At Mayo, for example, half our transplants are done delayed. So we do offer patients the choice of whether to do the transplant early or late. The trick, though, is that you need to be able to collect stem cells and cryopreserve for future use early in the disease course. So you have to give 3 or 4 cycles of initial therapy, get a good response, collect and freeze stem cells for future use, and you have to have the facilities and the ability to do that. If you do that, we believe that in standard risk patients that there's no data that early transplant is superior to delayed or vice versa. We therefore let patient philosophy and patient preference dictate that choice. The Dana-Farber Cancer Institute and the IFM, the Intergroup Francophone du Myelome, the French myeloma group, they've been doing a trial for many years now comparing a strategy of early versus delayed transplant, and results are expected soon. But the fact that the criteria change, I don't think affect that question. It's very relevant. We are already giving patients that option. I guess patients without CRAB, it probably makes it even more important for them to have the choice.
Okay. So why is it that stem cells need to be harvested early in treatment?
Yes, a couple of reasons for that. One is that early in the disease course, whatever myeloma cells contaminate the graft that you collect are still early in their disease evolution. Whereas if you try to collect late, you're going to have some contamination, but that contamination will be with cells that are far more clonally evolved. But the second and more important reason is that we know that long duration of therapy will affect mobilization of stem cells per se, and not just the quantity but also the quality of the stem cells, and may result in patients not able to engraft. And so we want to collect early to make sure that the normal stem cells are not damaged by a year or two of various drugs.
Okay. That makes sense. Okay, and do I have time for one more quick question?
Sure.
Okay, so the M spike, those patients that don't have an M spike, how are they going to be diagnosed?
Well, great question. 97% of patients with myeloma have a monoclonal protein that is detected in the serum, in the urine, or by the free light chain assay. There's a small percentage, probably 1 to 2% of myeloma patients who do not have any evidence of a secreted product. The diagnosis typically in these patients is made on either a bone marrow biopsy or biopsy of one of the lesions. And these patients typically present with a lytic lesion in one of the bones. You think it's myeloma and you do all the workup and there's nothing for monoclonal protein. So then you put a needle into one of those lesions and it comes out as plasmacytoma, and that's when you say, well, this is probably a non-secretory myeloma. So that's how the diagnosis is made. We are going to come out with a paper. There's a Mayo Clinic paper that will come out soon in the European Journal of Hematology, looking at the natural history of these patients and how they have fared with treatment. This is a very rare subgroup, but it looks like they have benefited a great deal from the new treatment advances as well. The main concern that I have is that many of our myeloma response criteria require patients to have a monoclonal protein, a measurable level, and so patients with non-secretory myeloma have been typically excluded from myeloma trials, and we are trying to see if we can somehow include them using either the free light chain assay or bone marrow plasma cell percentage as markers of disease.
Thank you very much.
Okay, Dr. Rajkumar, if you have time for one more question, would that be all right?
Sure.
Okay.
Yeah, absolutely.
We have one more question, 632-4412. Go ahead with your question.
Yes, hi. This is Joyce Schultz from Minnesota, and I just wanted to ask about how, this is a basic question about how I was diagnosed as a high-risk patient, as many other people out there have been also, and was wondering if that diagnosis changes as your disease, I've now had it for 6 years. Now, how has that changed? Am I still considered a high-risk patient? What things would make that change?
Well, good to hear you on this call. I think you've answered your question, which is that it does change.
Okay.
You are a great example of that. You were told you were high risk, and that means a median survival of approximately 2-3 years is what people talk about, and then you're more than double that and doing great. The thing to recognize is that medians are just estimates of what happens to the average person, and there are extremes on either end. Every time somebody tries to tell you that, this is approximately what's going to happen, there is always a chance that you're in one or the other tail, where very few patients are actually right average. So I try to tell people that any estimate of median time to progression or survival is applicable to about half the patients, and half the patients are going to do differently, much differently. Okay. And so I think biology is more revealed by what actually happens. So a patient who does well for many years is already declaring that no matter what the initial markers showed, that they are really not high risk, and that they have done well, and that the biology of the disease is dictated by more than that one factor that we checked at the beginning. Okay. So I think you want to make sure people are hopeful that the estimates and our decisions are based on what will happen to most patients, but not every patient. There are exceptions to every rule. There's patients who are P53 who live for many years, even though they have P53 and myeloma. So our estimates are just for the average patient, the exceptions to rules, and biology will declare itself over time, and that's probably more valuable than what you were told when you were first diagnosed.
Okay. All right. Thank you. It's been very informative, and thank you for being on this program, and thanks for those that provided it.
Okay. Thank you so much for your question. Well, Dr. Rajkumar, we've learned a lot by talking to you today, and we will certainly help spread the word about these different criteria. We're just very thankful for your leadership on this and the research that you and others are doing to move this field forward as quickly as possible, and we look forward to your upcoming smoldering paper.
Well, thank you so much, Jenny, for having me. I do want to again say that I owe a lot of thanks to the members of the International Myeloma Working Group, all 180 of them. It's a collective effort. It's not one person or 10 people or even the 34 authors. It's much more than that were involved in the criteria and many other papers. Also thankful to the IMF, which makes the IMWG possible. And thanks to you for having me on the show, for the excellent questions, and hope to see you again in the same show later on.
Okay, we will have you on again at a future time, and thank you. Thank you again.
Thank you.
Thanks for listening to another episode of Innovation in Myeloma. Join us for our next interview in 2015 as we learn more about how we as patients can help drive to a cure for myeloma by joining clinical trials.
Judy was boring.
Hello.
Then Judy discovered ChumbaCasino.com.
It's my little escape.
Now Judy's the life of the party.
Oh, baby, mama's bringing home the bacon.
Whoa, take it easy, Judy. The Chumba life is for everybody. So go to ChumbaCasino.com and play over 100 casino-style games. Join today and play for free for your chance to redeem some serious prizes. ChumbaCasino.com. No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.